Hello and welcome to this edition of the Rural Doctors Programme. I'm Jerry Gannon. As always, thanks for your company. In this programme, we're going to take a look at some topical medico-legal issues facing GPs. We'll also hear about Rural Health West's practice support programme, and we speak to Dr David Oldham about the Doctors' Health Advisory Service. But first up, let's join our panel for today's discussion. Professor Peter Wallace, Dr Warwick Ruse, Dr David Watson, they join Dr Olga Ward.
Welcome to the program.
Thank you.
Thank you.
Good afternoon.
And could I start by saying that there has been an enormous amount of press recently about the Professional Services Review Panel. This is an organisation with whom I think many doctors would prefer not to come in contact, but Warwick, you were recently the chair or involved with the Professional Services Review?
I was Deputy Director for Western Australia. And the first point is that the vast majority of doctors will never interact with even the first link in the PSR chain.
Yep. Well, could you tell us what this august body actually does and whom it consists of?
It consists of, from the doctor's point of view, other doctors. It's a peer review mechanism.
Yep.
It was actually set up 18 years ago in one of the rare consultations, I believe, David, between the AMA and the government, because they both realised there was a potential problem with Medicare rebates, not fraud, that's a separate problem, but with a bit of unconscious upgrading of fees, and also that the medical profession was now, like it or not, being subsidised by the government. Let's lay our cards on the table, we are. And the government did not want to be seen to be subsidising medical practice, which was less than acceptable.
Okay, so the PSR panel then reviews how doctors are billing Medicare? Is that what it's for? No?
The first stage is Medicare digests a huge amount of statistics.
Yep.
And for many years they have had the good and the great helping them with artificial neural networks and increasingly sophisticated statistics to look at patterns. The first big misapprehension is it's just a bell-shaped curve and they pick on the noble doctors who are on the right-hand side. It's not a bell-shaped curve, it's skewed to the right because I might work 20 hours a week, David might work 60, he's obviously going to have more item, whatever they are, than anybody else. And second, that it only looks at high volumes. They actually look at various ratios to see if, compared with their peers, and that's one of the points of contention, who is my peer, but with people who appear to be doing the same amount of work with the same patient demographic, there is anyone who's really outstanding. It is not an accusation that if you are outstanding statistically, you must be a criminal, but it's a fact of human life that people who stand out are either doing something very well or they're doing something very weird. And Medicare then sends a Medicare doctor who is in a very invidious position because he is a doctor, and he comes and knocks on the door and says, here's your figures, they are unusual. And the doctor involved says, oh, you know, in what way and what should I do to be a good doctor? And the poor Medicare guy can't tell them because he says, well, those are the figures. I have no idea what the patients are, and he is not authorised to look at 100 cases. Then the doctor hopefully talks to his peers and says, this is what Medicare, not yet PSR, has said to me, and or someone might come through from AgPal and point out that his notes are off the creek or something. But if the figures stay the same, then Medicare, still purely on the fact that this is an unusual pattern of practice, brings in the Professional Services Review and sends a referral to them saying, Warwick Ruse has unusual figures. It is possible, we're not saying it is, but it is possible that his practice in generating those was in some way inappropriate, which is the word provided in the Act. Would you kindly look into it?
Okay, so this sounds like quite a threatening sort of process for the doctor involved.
Well, it probably is seen as a threat because the next thing that happens is that the director of the Professional Services Review, who is a doctor, and all three of them have been at least part-time general practitioners, looks at the item numbers that Medicare has been concerned about, and for the first time says officially to the doctor, the PUR, the person under review, I would like to get a sample of these so that I, as a fellow doctor, can look at them. And there's a whole lot of legal underpinning for this, and the sampling is done scientifically. If the director, having looked at them, says, oh, silly old Medicare, 5 pap smears to every 7 patients, but it's Olga Ward, Women's Health Clinic, dopey Medicare, then the whole thing stops right there. Mm-hmm. Whereas if the director, looking at them as a fellow doctor, says it's only a small sample, but I don't like the look of this, he will then have a face-to-face discussion with the doctor, and the doctor will have been told at that stage, we really suggest that you get your MDO involved, or don't just be there on your own and terrified. And the director goes through what he has found in this very small sample, and explains from a position of power to this poor trembling doctor, if you go to a committee of 3 of your peers and this particular trend is seen in a larger sample, then they may find that on some of the cases you have delivered inappropriate practice. And if it's a bread and butter item like a 23 or a 36, of that sample of 25, if it comes to a final financial reckoning and they said, well, actually 20% of that sample were inappropriate, then it may be in the year involved the government would like back 20% of all those rebates. So it is a big deal financially for the doctor involved.
So, David, when does your medical defence actually get involved with this?
Look, our advice always would be that pretty well with the first contact that Warwick talks about, when one of the Medicare advisors comes out, that should be the time. You obviously can't do it before that because you don't know about it, but preferably well before the director gets involved. We, or whoever your MDO is, should know about it so that we can do 2 things. One is to provide advice, and the second is to provide support, because once you get that visit, it gets to be a lot more stressful and a lot more threatening. Doesn't matter how gentlemanly it is, it's a lot more threatening.
Warwick, you said that sometimes the director or the person who's reviewing the notes...
That is the director at that stage.
Yeah, will suggest to the doctor that they change their practice in some way. Is that change the way they document their notes, or is that
what happens is the director, if it's not a clear-cut case of a lot of unnecessary pain for that doctor, the Olga Ward pap smears in the Women's Health Clinic, we're very sorry it happened. The director has 2 choices. If he thinks that, yes, there is inappropriate practice here, and I've got a pretty good idea that if they went to a proper committee, it would be found that, but as inappropriate practice goes, it's not at the worst level. And even in the interview, I could see their sort of faces dropping and them realising, oh my God, am I doing that? He may offer them what's called a Section 92, because that's where it is in the legislation, agreement. The doctor has to agree that in the sample of practice that the director has brought to his attention, things were inappropriate. It will be part of the director's report but anonymised. The name will not be used. And the director has the power to say, and I think you should repay this amount of money, or I really think you should go to your college and get upgraded quickly. About 15% of cases that come to the director are immediately seen to be not necessary and stop. About 40 to 50% a Section 92 is offered, and I'll get back to that in a moment. However, if the director on his review says this is extremely bad practice, he may not even offer a Section 92. It's his decision whether he stops it there or whether it should go to the full force of a professional services review committee, which is the 3rd stage where I come in.
Peter, in view of this kind of process, where does the medical board actually get involved or fit in?
Surprisingly, little stuff comes through PSR, but there are 2 aspects that comes through. One is if a doctor has been involved and convicted of fraudulent behaviour, then there's some question as to whether they're a fit and proper person to be a doctor.
So this would have gone through then the criminal court arm of the Medicare
and then it comes back to us. And they may even at that time be in prison. Yep. So you have to be a fit and proper person to be a registered doctor. The second thing is that sometimes when the PSR process goes through a doctor's notes, they find the doctor is doing a lot of extraordinary things. Might be doing a lot of extraordinarily inappropriate tests or prescribing drugs in situations where they perhaps shouldn't be prescribed. And then there is the question of professional misconduct, and we look at that aspect of it, because the doctor may not be practicing safe medicine, basically. We're out to protect the public. So those are really the two circumstances that we would see the person.
And Warwick, could you maybe give us an example of something that might be investigated by the PSR? Say a concrete example rather than a concept?
This is one of the great problems that doctors, lawyers and even the judiciary think it's a charge. And the quite understandable people who don't understand the difference between that and peer review, they say, well, you know, what's the charge? And there is no charge. There is an Act of Parliament that says Medicare can trawl through its statistics and produce patterns which it believes have a higher than average possibility that there is inappropriate practice. And then the PSR is given a roving commission to look at that and see if that is or is not true. So there is no charge to be answered. Yeah. But the other thing, I think people sometimes worry that, oh, they'll pick on me for the fine detail. You know, I used this type of antihypertensive instead of the one that the great and good are saying we should do this year. It's not like that at all. We are seeing people, I mean, the classic one, which is completely de-identified but is famous in PSR, is a practitioner who for 18 months, in beautiful handwriting, put patient complains of rectal bleeding for 18 months, and then there is a letter from the surgeon describing this extremely advanced rectal cancer. It's that sort of thing that we stumble on.
And just before we leave the professional services review, there have been some quite adverse and fairly controversial findings published about and by the PSR. What sort of confidentiality is there if you're being investigated by them? And what happens if there's a legal challenge?
They're very strong on confidentiality. The hearings are closed. Everyone is charged. And, you know, I have to read the bit of the Act that says, you know, nothing is to leave this room. There have been some problems with, apparently, with the PSRs keeping the records, though, particularly with electronic records. Now they can sort of take a copy of your whole disc and medical director, and there were some problems when the auditor went through looking at the technicalities of that. Yep. The main thing I think everyone is aware of is a case called Kutlu, where the PUR's lawyers were doing their job to the utmost, and they went right back and said, was this committee properly constituted? What is proper constitution? It's by people who have been agreed with the AMA to be panel members. And it was found that, unfortunately, although there was informal and indirect communication with the AMA, things were not signed off. So by the rule of law, which we all agree with, that lawyer did his job. But my personal opinion is those findings, there's about 40 findings at least that have been scrapped. They're technically invalid, but I don't believe it had any bearing on the process.
Perhaps we'll leave the PSR and move on to something perhaps even more threatening. Peter, what happens when a complaint is made to the medical board?
Yes.
AHPRA as is now.
AHPRA.
But we're talking particularly about doctors here.
Now look, I have to keep this incredibly simple, because anything more complicated I'll get totally lost, as would almost anyone else working in the system, because it is really quite complicated. And I'll just illustrate that. This is the flow chart. That's page 1, page 2, etc., etc., etc.
A 4-page,
of where you go
flow chart.
when a notification comes in. So, put simply, notification comes in, and all notifications come for a committee called the Notifications Assessment Committee. And that committee is really, it's a bit like a, and everyone gets very upset when I say it's like sorting out sheep in a sheep race. Basically, what we're interested in is there any basis to this whatsoever or not. That is, it's really the first port of call. So it's a huge improvement on previous systems. This is one bit that I think has been improved, in that it is now possible for a complaint to come in 1 month, and within a couple of months it comes before the Notifications Assessment Committee, and they say, well, this is a load of hooey, and the complaint is all over and dropped, and all the stress and drama for the doctor goes at that point. However, Probably, well over 50% will move on down the line. And there are a lot of lines they can go
Is the doctor informed
down.
immediately that a complaint has been made?
Sometimes the complainant doesn't want the doctor to be informed, and there has to be some discussion about that before the doctor is informed. Sometimes, if it's a fraudulent case or police matter, it may be quite inappropriate. It may mess with the whole legal system to inform the doctor at that time. But if it's a sort of grumpy doctor complaint, you know, oh, he wasn't nice to me, she wasn't nice to me type of complaint, the doctor will hear about it very soon.
Yep.
So from the Notifications Assessment Committee, you can go in all sorts of directions as I indicated, but if the matter is not dropped, it will go before the next stage, which is the PPSC. But today I think we've just decided to drop that and call it just a sort of further notifications assessment, because it's full of acronyms. And that may do, which basically means a bit of investigation goes on. We might want to get some hospital notes, we might want to get some corroborative evidence from anyone who may have been involved in an incident or that type of thing. So we get that, and then we may, and usually actually what happens is we drop the case at that stage. But of course there are cases that need to go further. The other thing that may happen is that we may feel that the doctor's health is an issue. And so there is a special health committee, so the matter may be referred to the health committee, which is actually a different committee with different personnel on.
And that might be if you think the doctor is using drugs or seriously depressed or going psychotic or manic
psychiatric
or
something. Yep, exactly, that type of thing. Or even has poor eyesight and is not wearing glasses doing surgery, or stuff like that happens. The committee can also say, well, look, it's fairly clear the doctors admitted they swore at the patient, it wasn't a sensible thing to do, they were tired, they were grumpy, the patient was a dicky, annoying sort of patient, doctors really shouldn't swear at them, so I think we should caution this doctor. So we say, we propose to caution you, do you have anything to say? The doctor may say, God, it was a terrible day, and my wife left me, etc., all mitigating reasons as to why he might have sworn, and we may choose to say, oh, he had such a bad day, it's quite understandable, we won't caution you, or we may say, well, notwithstanding that, you shouldn't swear at patients, and that's your caution. The caution does not get put on their record, okay? So caution is quite a minor, the most minor.
All right.
Sort
Now, when
of
you talk
thing.
about putting on their record, you're talking about the
Registration.
little registration codicils that go with it?
Yep.
Yep.
And the other alternative is that we can put conditions on at that time. We might say that we don't think that you should be inserting implanons until you've shown us that you've been to the course and got the ticket for it, or something like that. And then the doctor goes off and finds an implant course and demonstrates that they can put an implant on in the right way around. Those are the sort of things.
Yep.
This, again, has the potential to simplify the system from where it was, and we're getting used to using these tools. It is taking a long time. It is a huge change. Now, if there are major misdemeanors, then if it is a matter of professional misconduct and quite serious, say sexual allegations and things like that, we would refer that matter to the State Administrative Tribunal, which is completely distanced.
That's a
from the
legal
medical
body,
board.
yeah?
That is a state legal body. Yep.
What happens, say, if a doctor's had a complaint made and they know they've screwed up, like, you know, they've put the implant on in the wrong way, or they've put it in and it's come out or something. David, how does the MDO kind of help the doctor to deal with the medical board? How does that work?
Look, again, I think even just advice from the medical board that there's been a complaint for most doctors is very stressful, and it should be followed immediately by contact with their MDO. Again, as I said before, there are two aspects to that. One is assisting the doctor in dealing with the board, and that may include going to any hearings that may be called. And the second is the sort of pastoral care peer support thing, which may very well not be done by staff, but by a member of council or the cases committee. It's something that we all take on in MDA National as members of the cases committee. And there is absolutely no question when you talk to anyone who's been involved on the receiving end of a complaint, you cannot be objective, and you have to have someone with you to help manage it, because it is just impossible otherwise. And you run the risk of saying things or putting things in writing that you'd regret afterwards. Similarly, when things are put in writing during the course of the process, we would always want to vet everything so that we've got something that goes back to the board that is not going to make the situation worse.
Yep. So, Peter, you with the board might ask the doctor themselves to write a report, and they would then contact their medical defence organisation and say, God, the board has asked me to write a report, what do I put in it? That's the sensible way of going about this?
That's exactly what happens, and we either get it signed by them, looking as if they've written it, or it actually blatantly comes written by a lawyer on their behalf, and that's fine.
So what right of appeal does a doctor have if a complaint has been made to the medical board and all these reports have gone in? Is it a kind of a right of appeal thing?
It's a really, really simple question with an answer that actually APRA don't know yet, because probably they have a right of appeal at every stage. So if when it goes from notifications committee to the next stage, which used to be called a PPSC, I beg your pardon, they might actually be able to appeal about that process if they wish to, or the next stage, if they're going to be asked to do some conditions, they may want to appeal, but all their appeals go to SAT, which is a completely independent body.
Warwick was saying that the PSR board was trying to move things along, but it was a slow process. This sounds like an extremely slow process.
Okay. The matters that are going to PSC and SAT at the moment, the majority would be 2010 notifications.
Huge.
There are some which actually precede that, but there are all sorts of complexities involved with that. But so the majority are 2010 ones, and then the 2011s won't get there for a bit.
So if a complaint is made and you think it may have some basis, or you think that the complainant is unlikely to let it drop, you may be looking at 18 months, 2 years before somebody really gets to review it thoroughly.
Without any problem at all, yeah.
How often do you see malicious complaints against professionals?
I think actually really deliberately malicious, I think, is extremely rare. I think frivolous is something that may actually be more common. We see a number of complaints, doctors versus doctors, and there are two situations which seem to really get doctors going. One is a breakup of partnerships, financial practice type partnerships, and Dr. X won't give Dr. Y the notes or the key or the disc or the something or other, and fur really flies, and we're expected to referee this. And the second is one doctor runs off with someone else's partner or spouse, and the fur fairly flies there. And they're actually not uncommon situations. You could call them malicious or frivolous, but they are sort of not really what we would expect that the Act was all about. Mm-hmm. What I think people need to be a bit aware of with the new Act is that sometimes other health workers can get together and say that a doctor is not performing properly. And we've actually had 2 or 3 instances where we feel that nurses, particularly in the theatre setting, have got a bit of a snidge against not a very outgoing anaesthetist or someone they think's not really that good. And so they all get together and they write a letter to the medical board. That causes no end of strife for that anaesthetist. So my advice there is get on with your colleagues, whoever they may be, and because whilst it may ultimately go nowhere, it's a lot of trouble for you.
So the moral of this story is bring beer on Fridays.
Absolutely.
I think, to be fair, often the only people who know, I was at one of our great hospitals a long time ago, and they asked for referees from doctors, and I said, I can get you any number you like. The people you really need to talk to are the endoscopy theatre sisters with whom I work, am I any good, and those GPs who no longer refer to me. Because it is very difficult to get, once people have passed an examination stage, has he turned into a grumpy old man who actually cuts corners 15 years out? And the only people who see it, because the surgeon is otherwise engaged, are the theatre staff. I think we have to be careful about slagging them, particularly after Bundaberg.
It's quite remarkable to get the feeling when you see some new file that this is malicious. But there are very definitely times when it's someone grieving over the loss of someone that leads to litigation or a complaint. And it's more about grief and bereavement than it is about poor practice or negligence. And I'm sure that's what the board says as well.
And we'll hold that discussion there for a moment. Rural Health West has recently developed a program for supporting GPs in the day-to-day running and administration of rural practices. We spoke to Rural Health West's Practice and Workforce Support Coordinator, Laura Harnett, about what the program can offer and how to access it.
In 2009, Rural Health West was funded by the Department of Health and Ageing to run a pilot program called the Business Support Unit. And my manager, Kelly Porter, ran that for nearly a year. And out of that, some items that needed addressing were in particular practice support. So practice managers were identified as an area of need. They needed education, support, assistance with updates in Medicare benefit schedule items and new incentives that were coming around. So we implemented a practice workforce support program. We've targeted three main areas. The first is the practice management business support tool. Second is employment contracts and agreements, and updates in the Medicare benefits schedule. Last year, in 2011, we engaged a private employment specialist law firm to help us create a series of template employment agreements and contracts for employee general practitioners and independent contractors. In 2012, we're also working on agreements for practice nurses, practice managers, and other allied health practice staff. Those employment contracts and agreements can be tailor-made to fit your practice needs and are templated ready for your use. The Practice Management Business Support Tool has 8 subjects in it at this stage, and we're working on an additional 2. It covers things like business support, Medicare benefit schedule, accreditation, telehealth, human resources, general practitioner job descriptions, and a variety of other things. The tool was distributed beginning of October last year, and to date about 30% of rural general practices have a copy in their office. The tool is a growing resource, so every month we will add additional fact sheets, templates and resources for practice managers. This month we've added 2 on the Practice Nurse Incentives Program, which is a new initiative from Medicare, and also the General Practitioner Job Description Template, which is particularly useful for practices when they're engaging new GPs to their practice. Medicare benefit schedule updates come out in November generally every year, but other interim updates can come out at any time. So we are trying to keep on top of all those updates and provide fact sheets on how practices can use these new item numbers in the day-to-day settings, for example, the new telehealth initiatives and the Practice Nurse Incentive Program. The Practice Management Business Support Tool can be ordered by contacting Rural Health West on 63894524. Or you can go to our website at the Practice Management Support page, where you can download fact sheets as we currently update them. And if you've got a question, if you've got some resources that you need, information that you need, please don't hesitate to contact Rural Health West Workforce Support Team, and we can tailor make resources and fact sheets specifically for your need, because if you've got a question, someone else will surely have the same question, and then we can work it up for download from our website or for inclusion in the Practice Management Support Tool.
Thanks, Laura. And now let's get back to the main discussion with Professor Peter Wallace, Dr Warwick Ruse, Dr David Watson and Dr Olga Ward.
All of you, at some time during this previous discussion, have mentioned medical notes and the adequacy or inadequacy thereof. I'm presuming that this must impact on all of your roles in your various organisations. Could you tell us a little bit about what you think makes an adequate medical note?
Could I start?
Yep.
If you are claiming Medicare benefits or issuing accounts on which patients from 1999 has been laid down in the bit that nobody reads, which went from 2 pages to about 200, that PSR committees must take into account when they're assessing appropriateness, was the record adequate and contemporaneous? And adequate is that there is sufficient history that the separate diagnosis and the separate management plan can be justified. in the recent troubles, much was made of the experienced doctor working very hard, and it was put to them that a note that said 3/7 bronchitis amoxil was an adequate medical record for, part of the momentous trivia of general practice. It was probably right. But I actually contacted one of the general practice accreditation, and they directed me to the college's standards, and that is just ancient history. You cannot do it. You have to put in my opinion, and certainly from PSRs when the peers are trying to assess the adequacy of the record, what the patient, what history you took so that you could arrive at the diagnosis. Because otherwise, headache could be anything, including a missed time bomb that went off that night.
Yep.
I mean, I think the standard that we should aspire to, we may not reach it, is that someone else could pick up the notes the next day and understood what we'd done and why. So it does need some detail of history. It does need some negatives as well as positives, both in history and examination. And you can think of different positives and negatives for both depending on the situation. And at least a working diagnosis should logically fall out of that information. And falling from that is some understanding of why we've done what we've done, either in respect of prescribing something or investigating or whatever, or all of the above. And if it doesn't pass that test, either within the practice itself or someone from outside, whether it's Warwick and the PSR troops, then it probably doesn't meet standards. Yeah. Now, plenty of people will argue, and I even put myself in this because I practice alone, my notes are only for me. And they do generate letters back to referring doctors, but it still has to meet that test. That if someone else, if I got hit by the proverbial bus and someone had to come in and look after my patients, they should be able to pick up any note of a current file and understand what I'm doing.
And Peter, I guess you must come across some pretty inadequate notes in your review process?
Well, absolutely. Yeah, I entirely agree with what the others have said, and I'm not going to repeat that, but there are incidents that happen with patients where the patient is clearly dissatisfied with what the doctor is offering or not offering. They bring in a child who's got a sore ear and the doctor says, well, look, really, it's going to get better, it doesn't need antibiotics. And there's a bit of a ding-dong about it and they go off looking huffy. It is very, very wise to write down in the notes there and then, the patient appeared to be unhappy with my advice and a few words about it, because if it turns around to bite you later, then it's all there and it clarifies things enormously down the track.
I think one of the problems is that the older school believes that there is the proper medical process and that the medical record then became an aide-memoire in case it was going to go on for a bit, or a pain in the bottom put out by bureaucrats. But I think Peter would probably agree, an adequate medical record is now part of the process of the medical consultation, not a bit of icing on the cake that the doctor can choose or to do or not to do. I think that's the message. And since 1999, that's been the law of the land. You just cannot say, well, I do it differently, because you're in serious trouble if you do.
And to illustrate away from MDA, when I became medical director at St John's at Subi, and we are the second biggest obstetrics hospital in the state, and even then the obstetricians were paying a lot of money for their indemnity cover. And I had a meeting with the members of the department quite early on in 1990. And I pointed out to them that one of the problems I was a bit concerned about was, did you know that only 1/3 of all deliveries in this hospital had a medical note about it? And they were the caesarean sections. All the others, the only note was kept by a midwife. And you have already just told me the midwives don't keep the birth register accurately either. So what are you doing? Every delivery has a written record. And that should be the same with all the records, not just confinements.
I think it's particularly difficult for general practice, but as David said, we're both physicians. I couldn't read my own handwriting a week later, but because I had done a letter at the time, the history I'd taken, the diagnosis I've arrived at, and the management plan was there. But I think we all know 50% of general practice, no one knows what it is biologically, and 45% of the rest is going to be self-limiting. And you don't know that till after the event, and you've got to keep a record of what they told you was happening to them, what you asked them what was happening to them, what you found when you examined them, and what you thought was happening, in case it's the time bomb that's going to go off a week later to that patient's detriment, or 2 years later when the board comes knocking at your door. It's self-preservation, and it's good for the patients, because people do fall under buses. Practices are no longer the one person who knew everybody for 30 years. There's a number of doctors. And it is interesting, I think, for any doctors watching in a multiple practice, you may be a little natural experiment. Instead of just writing your own, go and look at what some of the other doctors are writing. And if you think, my God, that's too much detail, that's probably what you should be doing.
Olga, one other small thing, and it's particularly a point to make for general practice. We've had quite a number of experiences where in a multi-doctor general practice, we've been advised by a member that he or she doesn't read the notes of other members of the practice. And this has cropped up in contexts, for example, where a mammogram's been ordered by one person. There have been 2 or 3 subsequent consultations with other members of the practice, and no one has paid attention to the fact that the mammogram was ordered, and it's been forgotten. And then we're confronted months later with a delay in diagnosis. And
I suppose this could easily happen if, you know, the patient of another doctor turns up on a Saturday morning to see you about an earache when you've got 25 other people in the waiting room. You're hardly likely to look up the mammogram that your colleague ordered 2 months ago.
That's right. But I think it probably is a larger hidden issue than we perhaps appreciate. That there is a tendency to look at our own notes. And I surveyed junior and senior doctors and nurses at St John's when I was preparing a particularly special grand round. And one of the questions I asked of nurses was, did you read doctors' notes? Getting back to Peter's comments about hospital notes. And of doctors, did you read nurses' notes? And I knew the answer. 80% of them said no.
Are they not multidisciplinary?
Yeah,
and
they're
just
multidisciplinary.
follow on?
And they only read the medical notes of the doctors and the nursing notes of the nurses.
Okay.
So in 2002, the College of GPs put out a policy statement on recalls and important diagnoses and those sort of things, and they said that important diagnoses should be put front and foremost at the front of the notes, so they were something that people could see very readily, not hidden in the minutiae, and that everybody should have a recall system. And so there are very real problems for a doctor and practices where something gets overlooked in the manner in which David has said, because actually it's now 10 years that sort of stuff should have been done for.
I mean, just having observed from a physician and taken a history and patients, I had that test done 6 weeks ago, and I haven't heard, so I assume it's all right. And I say they're wonderful people, but it's your boob, not theirs. Ring them up and say, I want to hear from the doctor that my mammogram is all right. And I'm sure most of the time it is, but I think it's very thin ice to not have some system whereby the patient is told having the test is one thing, the most important thing is hearing the result from the doctor.
Can we move on a little bit from that? And we've heard from David Oldham about the colleague of first contact. Rather related to that, David, could you give us a little update on mandatory reporting?
Well, it's got some interesting edges to it. The medical indemnity companies around Australia had a huge battle when APRA was getting itself up. Because if we take MDA National, we employ a number of medical practitioners who are registered and without exception are still in clinical practice as case managers. So the concern we had at the stage that was being talked about was, did this mean that our medically qualified case managers, if they were concerned about a member in the context of handling some matter, were then obliged to notify them? The answer is no, they don't. There is an exception. But it was a difficult thing to handle, and we actually went through a period where, because it first came in here, we were referring cases interstate to get by. The more difficult one and the more touching one for everyone in practice is if I see someone in my practice who's not just a doctor but working in any of the 10 healthcare professions that I'm concerned about, do I have to advise the board? With very few exceptions, I think our first duty is to treat the patient and look after them.
Yeah.
And one of my big concerns always has been that, at least in theory, everyone working in healthcare has potentially lost an inalienable right, and that is the right to confidentiality. And I still worry about it.
Mm. And I think we have a different law in Western Australia from the rest of Australia. Is that right, Peter?
Yes, I think it is different, but when it comes down to a number of things with APRA, in fact, the states are quite different from one state to the other, and I think this is one of the differences. Yeah.
The possibly impaired doctor who I pick up as a physician because of the continued trend of inadequate referrals and having missed the point, or the patient, have you had X done? Oh yes, Dr X did this or this, and you've got to try and stop your eyebrows going through the roof. And once again, if you get a trend for it, should that suspicion be mandatorily reported as an ethical obligation?
Well,
so this is your suspicion is this doctor just really isn't up to
That's
it.
right.
Yeah?
Not
That's
because
right.
there is a patient, but
And-
because
That's
I'm
right.
privileged to
So-
hear what.
This is not in a clinical context
That's right.
of Warwick seeing me as a patient. Now, although all this got a lot of publicity about 3 years ago, I think it would be fair to say that most of us have felt most of our practicing lives that we have some sort of moral obligation, if we're concerned about someone being unfit, to do something about it. Now, it used to be quite difficult. Let me illustrate with something that doesn't involve a doctor, but when I came to Western Australia, if I had a patient that I told could not drive because they were always drinking, I could do nothing about it 30 or 40 years ago. What you actually did, if you knew the system, was you rang up the police surgeon, and the police surgeon arranged for 2 coppers to go down the end of the patient's street and breathalyse him. Highly unethical. Now, of course, we have a system of medical fitness to drive, and doctors are protected by the statutes that govern that. The same applies to this sort of thing. The problem, and what has changed, is that notifications to the board now don't require statutory declarations. They used to. That was the only way the board would listen to a complaint 20 years ago. I think that's right, isn't it?
Yes, I believe it is.
So that I think if any of us do have concern, then there are a number of avenues that are open to us. One obviously would be to notify the board.
Yep.
Another might be to seek advice from our MDO. Most of the MDOs run programs to support impaired doctors, and it's in our interests to try and do something about it, because potentially they are a great risk to the funds that we hold. It is very difficult, I think, for any medical practitioner to face the decision alone of advising the board about suspicions of an impaired colleague. And it does no harm to get some advice.
Yeah. Is there a gentle way that APRA would, say, deal with the example that Warwick gave of a doctor that's consistently writing completely inadequate referrals and doesn't seem to kind of have twigged that 3 years of PR bleeding might be something a little more serious than hemorrhoids?
Is there a gentle way? No.
No,
No?
there's not.
No, there isn't a gentle way. But I think that patients have a right to be protected, and if everybody knows that someone's drinking and they go operating or practicing medicine or they're unfit, really, it's got to be reported, hasn't it? And it's quite a high bar for mandatory reporting. It's not just that somebody's a bit rude and grumpy and that sort of thing. It really has to be significantly bad behaviour.
Peter, what is the format for reporting? Do people phone the board, or do they have to put a letter or an email?
You can contact them any old way.
Yep.
You can phone them, you can email them, you can write to them.
Is there a
it
little
all
pro
gets
forma
there.
that you tick the boxes?
They will then send back a mountain of pro formas, yes.
But seriously, we all know that I might have had one bad referral on someone's bad day, but there has to be a web that can vibrate properly, and surely that's the board. If people can ring them and say, look, I don't know how far I should take this, but this is what I've seen, and the person taking the call says, I've never heard of him, send it. But if he says that's the fourth one this week, and none of the four know that they're talking, someone has to be in a position to collate that information, and I think, personally, and then set whatever wheels should be set in motion.
It is interesting. We do get that quite a lot, where you get something that appears to really be fairly inconsequential, and then 2 months later you've got something else about the same person, and boom, 2 weeks later you've got something else. You know, there are lots of red lights suddenly flashing.
Yep.
To illustrate with something that's not to do with mandatory reporting, it makes the point quite nicely. There's an unbelievable guy called Bill Runciman who lives and works in Adelaide and is the Professor of Anaesthetics and Intensive Care.
Yeah.
And he set up in 1988 a system of anonymous monitoring of adverse events in anaesthesia.
Mm-hmm.
And they published their first 2,000 incidents in 30 papers in the College Journal, Anaesthetics and Intensive Care, in 1992. And whereas there might have been 4 instances of this, like intubating the left main bronchus, all over the country, suddenly there were 4 together. And these 30 papers in one edition revolutionised anaesthesia and its practice in this country. I haven't seen much since. They've published, 2 years later, they published another 3,000. And it's the same principle, that it's what the board is there to do.
Mm-hmm.
But as I said before, we have a vested interest in it as well, and we certainly have systems within our office to manage that.
In a slightly different vein, and particularly relevant I think for solo doctors in rural practice, when are doctor relationships with patients considered inappropriate?
Essentially almost always it comes down to, see, it's all well and good while everyone's happy, but it is not well and good when they fall out. And quite a lot of stuff comes through on this, and it's the two people aren't on the same playing field by and large. If it's doctor and doctor, or perhaps doctor and a lawyer, then maybe they're on the same sort of parity. But when you have doctor and someone from a lay person who is a patient, it's really no-go. Mm-hmm. Under almost any circumstances. Many would say at no time thereafter, after the patient stops being the doctor and the doctor leaves the town and goes elsewhere, they feel that relationship is still flawed. That, I think, is largely to be tested. But yeah, it's basically almost never.
So if you fall in love with a local, they need to find another doctor in
Absolutely.
the next town.
Yes.
Any final comments from any of you about any of the stuff we've talked about?
I'd briefly like to just say that there are a few things we see a lot of which very, inverted commas, innocent doctors get caught.
Yep.
And the main thing is modesty and permission to examine. And so doctors who are doing pre-employment medicals, doing skin examinations, that sort of thing, and they're bearing bodies, they must remember curtains, paper knickers, sheets. They must remember the modesty bit. They will find themselves in trouble. It's a difficult situation, and we see a number of those, and people are gobsmacked when there's complaints raised about them, because it's been the last thing on their mind. They're banging through a whole lot of pre-employment medicals or something, and they're just not thinking straight about what's happening with the patient's view of what's going on. And I think that's really important. Permission to examine. Skin checks are causing a lot of trouble. People want to be skin checked. The doctor lifts the knickers and has a look into the genital area to see if there are any moles or anything like that. The patient feels they've been invaded. They get permission first before you put a hand or an eyeball anywhere. They're things that we see a lot of, and I think people need to be well aware of. And lastly, work notes. Be very careful to comply with the AMA guidelines or the college guidelines on writing work notes, because lawyers love work notes because they're written, everyone can see the evidence in front of them, and whilst it's a minor transgression, you know, if it's seen to be backdated or whatever, but if you actually put the words, this is backdated because the patient wasn't able to see me because they're in bed or something like this, it's wipes all out.
The patient reports that they were ill for 3 days and this is consistent with today's findings.
Absolutely,
That's all right.
absolutely. But it's the employers that bang these work notes in, and we get quite a lot of them. And it's just fuss that need never happen.
One of the things that came out of the recent PSR, genuine unhappiness, was at the very first interaction with Medicare, that the doctor said, well, what have I done wrong? And the Medicare advisor quite couldn't tell them because they didn't have notes. It's surely not beyond the wit of organised medicine in this country for Medicare to explain to the MDOs or the colleges what particular patterns their artificial intelligences have been found to be, the correlation with what they don't like.
So the doctor knows whether it's too many long consultations
That's right.
or too many consultations or
it's not
too
even-
much psychiatric
That's right, but
mental health
then
plans or
that someone
whatever.
who knows what they're doing, honest broker, paid for partly or wholly by the MDO or the doctor or a college, could come along and say, right, well, let's just do what the PSR committee might do in a year's time if this goes too far. Let's look at your notes. I'm an honest broker. This is going to be difficult, like having a rectal examination, sir. It might hurt, but it's in your interest. And if they can look at them and say, this is why you Medicare lit up, and if you go to the PSR, old Ruse will light up too, then it's up to them then to say, well, I'm the better doctor than them, I will defend myself to the wall, which I'm sure David does not like. Or they say, oh my God, did I really do that? And change it. Surely prevention early in this terrible chain, and it is a terrible chain. The people who are before the PSR don't like it at all, but believe it or not, folks, even I don't like sitting in judgment on my peers, but if I don't do it, someone else will, and they might even be a bureaucrat.
And David, final comment from you?
Well, yeah, it's just an extension of something that Peter said. The problem with a lot of the industrial type medicals, interestingly, I think hits specialists more than GPs, and there are several national organisations that provide independent specialists to do these examinations for lawyers, insurance companies and whatever. And we've had quite a number of these come back to us as complaints, which we've then had to handle with the board. And the problem there, which is different from where we practice in our own surgery, is that we don't set up the practice arrangements. So the doctor walks in and has to make good with whatever's there. And I'm sure Peter will remember one that's gone through relatively recently where that was exactly what happened, and there were no screens. And patients were sitting out in a corridor with, it was quite easy to hear through a flimsy wall what was going on in the consultation room. So that, it's often where people are practicing away from their own normal place. And it's a danger. I suppose the final thing to say is that in that type of third-party consultation, it's different. And it's very important that where things turn up, the doctor who's doing the examination must notify any adverse findings to the patient's GP. And we've had quite a sizable number of claims where that's not happened.
So you hear a roaring heart murmur at a pre-employment medical,
And
ring
it's
up
not
the
advised to the GP.
and advise the patient to go back to their
That's
GP
right.
as well.
Absolutely.
Well, thank you all for joining us today with this wide-ranging discussion. It's been terrific.
Thanks, Olga.
Thank you.
Thank you.
Well, finally tonight, the Doctors' Health Advisory Service assists doctors with a range of problems that may be affecting their lives. We caught up with Dr David Oldham from the WA branch of the Doctors' Health Advisory Service about the support they can offer and the types of issues they can advise on.
The colleague of first contact, which was operational in Western Australia for 10 to 15 years, has changed its name. It's now called the Doctors' Health Advisory Service to bring it into line with similar service in the other states of Australia. We're finding lots of interstate doctors were coming to Australia and not recognising the name colleague of first contact, but they do recognise the name Doctors' Health Advisory Service. The service is a 24-hour, 7-day-a-week call line, which is staffed by 4 experienced GPs with an interest in doctors' health. And if a doctor or a concerned friend or colleague of the doctor ring the line, one of the GPs will ring them back and discuss their problem with them. There's also a support psychiatrist available, both to support the GPs, and is also available to see doctors on an urgent basis if needed. We encourage doctors to go through conventional means, mainstream medical services for their treatment, but if they're not quite sure what to do or their problem's a little bit different, for example, we have people ringing up about substance abuse, gambling problems. They might have a problem with the medical board that they want to discuss with a confidential party. We are able to assist in that regard. We talk through the problem with them and then we advise them on where to go to help. The doctors on the panel themselves do not actually provide ongoing telephone counselling. We might do an initial debriefing. A typical call could last 5 minutes to an hour, but we then advise the doctor on where to go once we've clarified what the problem is with them. The advice we give to doctors is the same as we'd give to any patients. First of all, to take a preventive approach to life and lifestyle. So smoking, doctors are actually very good at not smoking and they have a lower incidence of smoking-related illness than the rest of the population. Drinking though is on a par with the population, so that's an area doctors can improve in, and exercise is on a par with the population, so that's another area doctors can improve in. Where doctors aren't as good as the general population is in having their own GP. Less than 50% of doctors and GPs can identify a GP that they go to. So I encourage doctors to have their own GP, someone that they either go to for their regular checks and they need a GP that they can go to if they are having health problems. So they need to identify who they'll go to if they have to. Often there's a larger regional town which has GPs in it that the doctor could get to know. They ask around friends and colleagues who's a good GP in the area, same as a patient would find out, and make a time to see that GP either when they're visiting that larger regional centre or make a special visit there. Alternatively, there are plenty of GPs in Perth who are very happy to see their colleagues, metropolitan and country, so coming to Perth is also an option. It's true that as a whole, doctors aren't very good at looking after their health. They're busy people, they have difficulty getting time off work, actually accepting that they might have a health problem. There's often an element of denial. Second, even if they do accept that there is a health problem, then they don't tend to seek treatment like normal patients would. They either tend to treat themselves, which is fraught with problems, or they seek informal opinions from colleagues. And informal opinions are also fraught with danger. And thirdly, doctors know other doctors and they often want to keep their problems confidential. The most common calls that we get are about anxiety and depression in our colleagues, so psychological problems. Sometimes they're more severe, such as bipolar or psychosis or suicidal ideation. So there's the psychological spectrum. We're also getting calls, increasing calls from rural areas, from doctors, particularly those from interstate or overseas, who are feeling quite socially isolated, and it's having an impact on them and their families, and often they're in the early stages of anxiety or depression as a consequence. So my take-home message for GPs and rural GPs in particular is to take care of yourself, have a preventive approach to your lifestyle, watch the smoking, drinking, get that regular exercise, and also to organise for yourself to have a GP. That's probably the most important thing, and the best thing that you can do for yourself is have a GP and have regular checkups by that GP.
Well, that's all we have time for tonight. Thanks again to all our guests, Professor Peter Wallace, Dr Warwick Ruse, Dr David Watson, Dr David Oldham, and of course Laura Harnett. And remember, this programme and any of our previous programmes going back to 2008 are available to access on our website at ruralhealthwest.com.au. We're back on April 3rd with a programme focusing on women's health. In the meantime, I'm Jerry Gannon. Thanks for joining us.